webinar series that we bring you is to bring together addiction researchers, clinicians, and other experts from the sector to discuss emerging research and challenges that we're facing in the addiction field. And this is the second of 4 webinars that we are running in 2020. All the webinars are recorded and they'll be available for viewing at a later date. And our previous webinar is currently available. Our next webinar will be on Thursday, the 22nd of October, which will be looking at the impact of COVID-19 on gambling behaviours, both positives, negatives, and vulnerabilities. And I'll talk a bit more about who we have lined up for that date at the end of this webinar. So it's my great pleasure at this point to introduce our 3 key speakers. The first 2 speakers, Professor Paul Dietze and Associate Professor Chris Pearce, will be speaking for around 15 minutes each on the respective areas. And then our discussant, Dr. Shalini and Arunogiri, will be talking about their presentations and bringing some ideas of our own, and then be facilitating the Q&A answer session. So you'll see at the bottom of your screen a Q&A box. Please, if you have any questions throughout the presentation, please write those questions in the Q&A box rather than in the chat box. And that will allow Shalini to have a look at those questions and be able to direct them to our speakers in the Q&A session. So at this point, I'd just like to give you a bit of information on our key speakers. So Professor Paul Dietze heads the Alcohol and Other Drug Research Program at the Burnet Institute. He has over 20 years experience and is one of the leading researchers in the addiction field in Australia, with extensive history of significant and innovative research into the impact of alcohol and other drugs in the community. He's been the recipient of numerous awards and prizes and is currently supported by an NHMRC Senior Research Fellowship. Since 2008, he has led the SuperMIX and VMAX prospective cohort studies of people who use drugs that provide insight into patterns of drug use and related harms in the Victorian community. And he'll be talking today on the effects of vulnerable populations findings from the SuperMIX cohort. Our second speaker is Associate Professor Chris Pearce, who's a practicing clinician in emergency medicine, general practice, and anaesthetics. Since the mid-90s, he has a keen interest in health informatics and has watched the computerization of general practice. A PhD on the ways computers were changing the consultation followed, and he's written many articles on the social impacts of computing and the change in adoption issues. As Director of Research for Outcome Health, he is exploring the issues of data quality and use for quality improvement purposes. Of late, this is including applications of AI in the clinical interaction and what it means for the patient-doctor relationship. He was also the clinical design lead for the Australian National Shared Record called My Health Record. And our discussant today is Dr. Shalini Arunogiri, who's a consultant addiction psychiatrist here at Turning Point and a clinician researcher. She's the Deputy Clinical Director at Turning Point and Deputy Head of the Department of Psychiatry at the Central Clinical School at Monash University. She's also chaired the College of Psychiatrists by National Faculty of Addiction Psychiatry. Her clinical and research interests include methamphetamine use and mental health problems and women's health and addictive disorders. And she's been an investigator on multiple Australian clinical trials. She's also a very passionate advocate for women in STEM and academia. So they're the great talks ahead for us and great speakers we have. And at this point, I'd like to hand over to Professor Paul Dietze, who will be talking on the effects of vulnerable populations, findings from the SuperMIX cohort. Please welcome.
Thanks, Dan. I too would like to acknowledge the traditional owners of the land on which we're all meeting. I'm on Wurundjeri land. I'd probably rather be in Tangerang land, which is somewhere where I can also normally stay. I'm struggling to get my screen shared, sorry. Yeah, COVID doesn't allow that at the moment. I'd like to acknowledge elders past, present and emerging and note that land was never ceded. So today I am going to, hopefully you can see this now, and today I'm going to speak to you about some of the findings that we've got coming through some of our prospective cohort studies, and just highlight the importance of having prospective studies for surveillance in these kinds of times and in these extraordinary circumstances. So I'll talk about 2 particular studies. So we have a range of fieldwork studies at the Burnet. And the two that I'll be talking about today are two of our prospective cohorts. So one of them is VMAX, which is a study of people who use methamphetamine. Almost all of the people were recruited on the basis of smoking methamphetamine rather than injecting. And we recruited most of the sample in 2017, but we have been replacing people lost to follow-up as we've been going along. Has annual face-to-face interviews and telephone interviews. You can see some of the characteristics there. It mixes self-report and record linkage, which the other study, a lot of our studies do at the Burnet, but I'll be just talking about some self-report data that we have at the moment. And the other cohort study I want to talk about is SuperMIX, which we started in 2008, 2009. Again, it has annual face-to-face interviews. It's around about it's just over 1,300 people in the cohort now. And it has a similar kind of design. The one key thing though is that during the COVID pandemic, we have actually had to pivot and change the way in which we do our interviews. And I want to pay a special shout out to the team for being able to do this. And so rather than just face-to-face interviews, we're now doing most of our interviews on telephone or through video conference. I just want to highlight what prospective studies can do. I mean, basically they involve following up people over time at multiple time points and seeing how they evolve over time. The beauty of prospective cohort study as well is that you can look at how exposures to certain things might impact on various health outcomes over time. So say, for example, a non-fatal overdose, for example, amongst those exposed to something like using a supervised injecting facility or something like that, versus those who aren't exposed. And so there's all sorts of things that prospective cohort studies are important for. And in the context of COVID, there's been an awful lot of work that's gone on now doing cross-sectional surveys of people after the COVID restrictions have been implemented and asking people whether or not they believe their drug use might have increased or believe it might have decreased and so forth. But there's a lot of bias in relation to those sorts of answers to those sorts of questions. And so it's really important to have comparative data from the past to be able to look at what people say and how that actually corresponds with what they did previously. But the cohort studies that we run, because we're working with people who are vulnerable for a range of reasons, we really need to make sure that we have their trust and we engage ethically and we have an understanding of where they're at the moment. As I said, we have these annual questionnaires where we ask about demographics, drug use history, drug market access, and so forth. For SuperMIX and some of our other cohort studies, we collect blood biosamples, but then we have all of this data linkage here, which I won't be talking about today, but it's one of the more powerful elements of the studies that we have access to. So we have, for example, in SuperMIX, the cohort of people who inject drugs, we have around about 500,000 Medicare benefit items that we are in the process of analysing related to the use of GPs and other Medicare benefit schedule things. So it's pretty exciting data and very powerful and takes us a little bit beyond the self-report that we normally rely on. Key thing about SuperMIX is it's designed to determine the trajectories of injecting drug use, and we're recruited across all of these different areas of Melbourne. In 2017, we had another big recruitment drive, and we included Geelong and Box Hill in the Eastern Metro. But we work a lot with services in these different areas. So there's a mention of all the services there, and I want to give a special mention to their support that they continue to provide us and the participants that we work with. So during the COVID period, we were able to interview so far 93 people who we'd already interviewed, and we're able to look at whether or not things had changed for them prior to compared to their prior situation. And so you can see when we look at average weekly income during the past 6 months, you can see there was more people who reported having an average weekly income over $600 per week, so 27% versus 17%. People's accommodation status, so there was decrease in people reporting unstable accommodation. And remember, this is people who, sorry, I should have said, this is us comparing the most recent interview before COVID that we did with these people, and then asking them what things were like during restrictions. In terms of things like the anxiety and depression scales that we have, we didn't actually see any major changes or anything like that. And employment status, still the majority of people are unemployed. When we turn to their drug use patterns, you can see there's, sorry, there should be a star here to say that there was a big drop in the number of times that people injected in the past month. So basically, injecting by people in the cohort trailed off. Prices paid for heroin at the time didn't really change very much. There's a slight increase in the price per gram, but that wasn't statistically significant. But in terms of methamphetamine prices, there's been a big increase in methamphetamine prices. In SuperMIX, it only comes up at about $50 per gram. But you'll see in the VMAX cohort I'll talk about in a minute, the comparative prices have gone up even more. Looking at VMAX, so VMAX basically is a very similar sort of study to SuperMIX, except the focus, as I said before, is on people who smoke methamphetamine. And importantly as well, we recruited participants from 3 regional areas in Victoria, not just in Melbourne. Again, we're basically identifying the natural course of methamphetamine and other drug use for this group, and looking at key drivers related to that, and look at what sort of intervention points there are for delivering services and where we should be focusing our efforts. So again, I'll talk to the same variables that I mentioned in relation to SuperMIX. So you'll see here, in this case, we were able to interview 222 people during the COVID period. So this is after March 30 effectively. And then this is comparing against their most recent interview prior to March, basically. And you can see again, like in SuperMIX, the average income of people increased. So 45% reported that they had a higher average income. There's a slight drop in employment. So from going from 37% of people saying that they were employed down to 29%. No change in accommodation score. And again, we saw no change in anxiety or depression scores in the cohort. So some pretty interesting contrast there in terms of differences in employment status, but at the same time, an increase in income. And obviously that's a reflection of things such as JobKeeper and JobSeeker changes that have occurred for people who are receiving benefits in the case of JobSeeker, or were employed previously in the case of JobKeeper. Turning on to drug use patterns, and I should say these data analyses are really hot off the press, and we're in the process of turning this into a bulletin and paper to go with it. So methamphetamine use in the past month, you can see, has actually dropped off. So before COVID, people, 57% of the cohort said they'd used methamphetamine in the past month. It dropped down to 47%. No change in cannabis use. And actually, what comes as a little bit of a surprise, there wasn't any kind of shift of substance use from methamphetamine to alcohol. And you can see there's actually a small drop in the percentage who reported using alcohol in the previous month. But here's where we see an increase in the price paid for methamphetamine per gram. So for those who were using methamphetamine during the COVID period, they were paying around about a third more, and quite a big range there as well compared to pre-COVID times. I also just want to mention a couple of other studies that we mentioned. So they're the prospective ones that, to me, they're the most powerful indication of what's going on in the methamphetamine market and drug use market more broadly, because we actually have comparative data prior to the onset of the COVID restrictions. But we do actually have some some cross-sectional data as well, which we are looking at to try and sort of help inform the way in which we interpret our cohort data as well. And so there's other fieldwork studies that we have going, and the illicit drug reporting system, the ecstasy and related drug reporting system are in the process of putting out some bulletins related to COVID. And I'll send the links through to the MARC organisers if people want to follow those up. But I want to talk briefly about some work we're doing with some of the needle and syringe programs across Melbourne, looking at doing some snapshot questions of their clients. You know, the sample size there ends up being variable because it's basically just people approached as they come to collect equipment. Again, it's self-report data and it's cross-sectional, but it is interesting nonetheless to have a look at what sorts of things people are reporting. So this is the second round of this work that we did in June 2020. So this is during the COVID period. And I won't talk too much about the people's reports of their last drug injected because we don't actually have the comparative data for these people prior to COVID, but I do want to point out some things that they've told us. So basically since COVID-19 began, 40% of this sample reported the drugs are harder to access. Most felt that access has stayed largely the same, and a very small number of people said things are easier to access. 23% of them have been tested for COVID-19, which is actually interesting, and it'll be interesting to monitor over time. We are looking at, we have just rerun another one of these snapshot surveys, and it'll be interesting to compare. And only 12% reported having difficulty accessing healthcare due to COVID-19 if they tried to, which I think is encouraging, given that a lot of work's gone into you know, changing the way in which these services are delivered to people who inject drugs during the COVID period. So it's good to see that only a smallish number of people reported access issues. I should point out, I think this sample size here is around about 600 people. So just some really brief conclusions. Basically, you know, we're not really seeing these major changes in drug use or drug purchasing patterns in our cohort studies. There's some weak evidence of changes in demographics, some evidence of improved mental health that we need to follow up on. Clearly an increase in the price of methamphetamine though. That's something that is important to keep following on. What we need now to do is to look at the repeated measures analysis of being in stage 4 lockdown. So obviously our cohorts are largely Melbourne based. We do have some people recruited in regional Victoria, and it's going to be really interesting to see what sort of impact stage 4 has actually had with the curfews and so on. I'd just like to acknowledge all of the participants involved in the study, and as I said before, the community health services and other services that have helped us at the recruitment sites, the fieldwork team, including the snapshot team, all the chief investigators involved. And all of these studies are either funded by the National Health and Medical Research Council, Colonial Foundation, or through the Commonwealth Department of Health and Ageing. So yeah, that's where I'd like to finish, and I can't see any questions for immediate answer or anything, but I guess we'll be talking more when Shalini does discuss the presentations. So thank you for listening, and I'll hand over.
Thanks, Paul, and I'll hand over now to Chris. And just to remind people just on the point that Paul just raised, please I just going to remind people, any questions you have, please put them in the Q&A section, and Shalini will be going through them in the discussing period. Over to Chris.
Yeah. Thanks very much, Dan. That was me desperately coming off mute, as you do with these Zoom meetings. So, look, thanks very much for the invitation to talk here, and I'm hoping that you're now looking at my slide. I'm here now to talk to you about primary care data. Now, primary care data and primary care activity has often been a bit of a black hole in terms of getting good, accurate data. Hospital systems are well versed in it, plus especially at state-based level, there's a lot of resources put into hospitals. General practice being a much more disparate set of individual private businesses has always been much harder to access. What we've had now is we've got several opportunities though coming up. There are already available some very large national data sets, basically the MBS and the PBS. But we have to remember that they are they're administrative data, which makes the interpretation of them quite difficult. At the other level, most universities will be running some sort of what they call practice-based research networks. And they're usually, 50 or less, 5, 10 practices, in which the university puts a lot of resources in terms of assessing interventions and trying to describe some workflow issues in general practice. However, what I'm going to talk about now is one of two sort of middle level research data sets available. And I work with Outcome Health, and Outcome Health provides some data analytics services to the primary health networks. So what we're developing here and have developed is a very, very large data set. This is big data in every way, shape or form. We have a program that now extracts data from over 1,000 general practices. We actually do the extractions on a daily basis. We have some 20 million patient records, which represents probably about, in effect, half of the Australian population. Although remembering that general practice is longitudinal data, that doesn't mean that it's 12 million patients in and of the last 6 months, because we know that patients are very mobile and over a 10-year period, they're going to move. To give you an idea of what this means, what we have, because we work with the primary health networks, is a very geographically intense data set. Basically, I can't tell you anything about what's happening in Queensland, but if you want to know about southern Sydney or eastern Victoria, I have all of the data that you could possibly want. Because we work with the PHNs, so the PHNs provide the service to their practices, which means that we have most of the practices within our 6 PHNs. And the other thing that is worth pointing out is that this is not a research data set primarily. The basic program is about providing change management and quality assurance to general practices. So what you can see here now is a screenshot of what's available at the practice level. And you can see for the practices, they get some information around how many care plans they've got, eligible for care plan review, sort of stuff that helps them to run their businesses and monitor the care of their patients. You can see on the left-hand side of the screen there where the real power is, because they can then cut and slice the data to suit their purposes according to specific diagnoses, specific GPs, pathology tests, so they can look up how many patients with a given condition have had the screening tests they need. At the practice level, they can generate lists, identifiable patient lists that they can work with. What we then do is we take completely de-identified data out of the practice, because the second tier is to provide population health statistics for the PHNs to organise their service. But the unique thing that we then do is that we then all parcel that all up at a population health level, and we actually make the data available to researchers for projects that tend to be collaborative and focused around improving the care of general practice. But the other thing that we've been able to do, because of the nature of the program, which is about change management, is we developed the ability early this year to do basically real-time analytics. So as I said, we do the extractions daily. At the moment, we deliver a COVID report to the practices and the PHNs every day about their activity. And that gives us some benefits. So what I'm going to talk about now is some stuff to do with mental health and some drug use that's relevant to the Addiction Research Centre, but they're not a particular agenda I have. I've actually just picked out some things to try and show you the potential of what we've got, rather than actually focused on a specific question. So, of course, let's start looking at mental health. So on the left, you can see that one of the things that we've done is we've made a grouping of mental health conditions. And you can see that of all the mental health conditions that we've grouped in there, we've got 687,000 diagnoses on 479,000 individual patients. And the list there is just straight counts. And I have to say that that's about a quarter of all of the potential mental health diagnoses we've got. So you get an idea of the size of the data set. And because I know this will be of interest to many people, you can see on the right there, we've done a cut of the mode of consultation for people with mental health problems. And you can see at the moment, it looks there like that 60% face-to-face for the general all consultations and 39% telephone. And for those with mental health, 61 and 37. Now, that's very interesting, but it's also a very unsophisticated figure. If I go to the next slide here, what you can see is actually, this is a week by week recording of the consultation mode to do with the that mental health group that I talked about before. So that's all patients who've had, in this particular case, a diagnosis of mental health recorded in their general practice in the continuing section of the history. And you can see that the table from before is actually a bit misleading, because what we have here is, you can see obviously at week 11, 12, which is when the telehealth items were introduced, there's a spectacular increase. We can see both of them about week 15, which is about the peak time of the first lockdown, which was a nationwide lockdown. There's a bit of a drop off in the consultations in general. And then we sort of have this steady flow, but you can see that basically here we are at week 36, and telephone, and particularly if you go down the bottom, you can see video consultations. That's the blue line down at the bottom, of which there's not a lot of. If you add them together though, but the telehealth is actually the majority of the contacts, but effectively it's basically 50-50. And I think that's an astounding change for the way general practice is delivering care at the moment. Now, it's interesting that you look at that and you say, well, mental health as a condition, but there'll be some people in that list, because that's a very broad condition, is that will have diagnoses that may not affect them very much or may not be directly relevant. So another way that we've cut the data is we've looked at the item numbers for having a mental health care plan. And as I'm sure you know, care plans are things that GPs can organise. It gives them access to some greater resources, particularly access to Medicare-funded psychology consultations. And you can see here there's actually a very different view to the first one. where telehealth took a much longer time to take off. It's increased, interestingly, at 31 to 34 weeks, which of course is the peak of the second lockdown in Victoria. And I suspect that that's a factor in that. But the interpretation we put on this is that for care plans, people are doing the stuff majority face-to-face, but for the ongoing care, the follow-ups, they're actually being more comfortable doing it with telehealth, which actually, you know, makes a lot of intuitive sense. So the next thing I wanted to point out is that we can track also, therefore, diagnoses. And the slide here is new diagnoses of a mental health problem. So any of those mental health things that were in that first slide, that list, what we've done here is recorded anyone that's appeared for the first time in the GP record. We've done a year-on-year comparison, so the figures here are percentages. So if you look there at week 14, which is the bottom part, there are 30% less mental health diagnoses compared to the same time the year before. Whereas at week 21, there are 17% more mental health diagnoses than the same time last year. And again, it gives you a good perspective of the fact that prior to that week 10, it's pretty much running exactly as you'd expect. There's a complete drop-off, which actually relates to a complete drop-off in activity. That was the time when no one was going to the GP in general. And then we've got this consistent 12, 15, 20% rise in mental health problems across the board, and it's continuing. We can look at that by well, can we validate that by looking at medications? Because presumably, if that's the case, then the medications are going to increase. And lo and behold, they are doing that as well. So we gather medicines and classify them according to what's called the WHO's ATC code, which has 5 levels. So we have, we can track them at sort of the level of, you know, very broad, just mental health conditions, all the way down to individual drugs, as you can see here. And I've picked out here, just for examples, the anxiolytics, the benzodiazepines, and the antidepressants. And we can see here, so the green represents a percentage increase on the previous year. And we can see for the latter half of the year, it's just all green, and we're talking some very interesting figures of, you know, 40, 30% there for citalopram, right across the board. Now, this is some stuff that we do that we can deliver to the PHNs. You've got to remember that underlying that is a data set that I can give you the dosages, the frequency, the number of repeats, and even relate it to specific consultations, which makes it an astounding research data set. And it's the reason why people ask me if I'm interested in MBS and PBS data, and the answer is no, I'm not, because I've got a much richer data set here that I can play with. The last bit I thought I'd just have a look at for us was specific opioids, because this for me is a very interesting and somewhat concerning picture for the next few months. So for this one, I've extracted a year-on-year comparison for the opioid group, which is ATC level 3. And we can see a year-on-year comparison on the number of prescriptions. So the bottom figure, we can see that across all of the practices, they're running at about, let's say, about 7,000 scripts per week for the various opioids. Alas, we can see that for this year, which is the top figure, we're seeing an escalation in opioid prescriptions across time. And again, say, well, opioids, but you know, which ones? in order to make a bit more sense of this, I filtered this to a minimum of 1,000 scripts per week. And you can see that the big winners, if you like, here are tapentadol, tramadol, and the natural opiums, who are well into the 100% year on year, than compared to the other ones. So this is all about providing information that we can feed back to the PHNs and feed back directly to general practice to get them to try and alter and change their behaviour, but also it just outlines up to me the potential of a really good primary care data set, and particularly because we've got this geographical intense area, the potential of us doing data linkage with local hospitals, we can basically, map the entire, the opioid burden across the healthcare system. And thank you very much for listening to me. And I hand over now to Shalini, and we're going to have some discussion.
Thanks very much, Chris, for that fascinating data. I'm just going to share my screen with everyone. All right, so I'm just going to take everyone through just a couple of slides to just try and tie a lot of this stuff together. We've had some really interesting data from everyone from a couple of different cohorts and different groups in the population. So I think what we're hearing overall is really that, I think we'll all agree it's been an extraordinary year. The year alone, just in Australia, we've had fires, we've had lockdowns, we've had the public housing situation in Melbourne, we've even had locusts across bits of Australia. So unsurprisingly, I think as a nation, we've gone through an extraordinary, as a nation, globally, we've gone through extraordinary stress, and unsurprisingly, I think we're all expecting that there is an impact on mental health, and that's what we're discussing at the moment. I'd like to share just some information around the impact specifically around women, and some of the data that's come through in the last few months, really. Overall, I think at the start of the pandemic, this is going back to March or so, there was a lot of concern about potential increase in alcohol use across the population. I think there was a lot of stockpiling happening with increasing in purchases, but not necessarily increases across the population in amounts of use. So the data from the ABS and the Australian Statistics databases have really shown that across the population, consumption has been relatively stable, and particularly there are significant subsets who have actually reported decreasing the amount of alcohol that they're using. But if we look at just specific groups, and here if we look at women as compared to men actually reported an increase in drinking. So of the total proportion of the population is reported drinking more, women are represented. And there are a number of reasons why. Mental health overall appears to have a disproportionate impact on women as compared to men on a population level. And there's a whole range of different factors that might be associated with that. Self-reported levels of sort of stress and depression and anxiety have increased. Self-reported levels of suicidal thoughts have increased over this period. I think what we're also seeing is that there's increased reports of a number of stresses that affect women disproportionately, including increased reports of family violence. A survey that came through just last month from the Monash gender unit actually looked at increases in frequency, severity and complexity of family violence calls coming through to family violence practitioners in Victoria. We're also seeing disproportionate impact on economic burden from the perspective that many of the casual work and frontline workforce sectors are really driven by females more than males, and some of the economic policies that have been brought through have disproportionately affected women as a result. I think this is one of the most significant things that many women who are probably on the call can appreciate. I think women have been affected significantly through the year as parents, and I think parents across the board have been affected. Women have had more than 3 times more likely than men to report looking after children full-time during this year, and specifically having a child caring role in the surveys that have been conducted so far are a significant and strong predictor of increased alcohol use, specifically in women. So alongside this is industry and their role in terms of advertising and in social media. And really across the year, we've seen lots of memes and lots of ads as well on television and media, where there's been a real normalization of alcohol use as a coping strategy for women in particular, and also for parents during lockdown. And so we've seen a significant sort of impact on women through that. So this is probably going to continue to be part of the conversation going forward. It's an emerging sort of concern in terms of behaviours that have developed over the course of this year as coping strategies could become part of the new normals that are going forward. That's been associated with the Australian Drug Foundation's campaign around little habits becoming big habits. And really, this is something we probably need to keep an eye on kind of going forward and to gather better and longitudinal data around to really understand what the impact truly is. So on that note, we might open up the Q&A and relate to some of the really interesting data that was brought forward by the other panelists. I might invite everyone to turn their videos on with the other speakers. Stop sharing that. So Paul, Chris, we've had lots of really interesting questions come through. I thought I might open with one question that's crossed a few different themes. I might direct this to you, Paul, in the first instance. It's really around sort of the mental health data that you presented in the MIX and SuperMIX cohorts, which I think a few people have raised some questions around because it's in contrast, I think, with what you know, the information that Chris was presenting, and certainly the information that overall is kind of in the media and in the news a lot about overall having an increase in mental health problems during the pandemic. Do you have any kind of comments to make on that in relation to the cohorts and specifically?
Sure. So I guess the point to make is that a lot of the people in the cohort were already suffering from a range of mental health problems. And so as a consequence, there's not, one, there's not that much room to move up on those scales that we have, but also, you know, you might find a range of things that are happening to people actually, you know, would lead to improvements in mental health. So, as I said, I think I said, you know, changes in housing status and things like that, from moving from unstable to stable accommodation would potentially be associated with that. And there's a, you know, there's obviously been a really big effort to try and get people who are unstably housed into more stable accommodation funded by the government because of the COVID impacts, and then and other things as well. I mean, an increase in income. You know, if people are struggling to sometimes find enough money for food and things, which some people do report in our cohort, if they then do have enough money for food and so forth, then that helps. And, you know, potentially as well, changes in patterns of drug use. I mean, we know that methamphetamine is associated with a range of negative mental health outcomes, and if their methamphetamine use is declining a little, then that might change things. Yeah, so there's a whole raft of reasons, and we've only just begun to explore these data, and what will be really interesting is contrasting stage 3 and 4. I mean, I look at Chris's data in relation to opioids in particular, and I'm really concerned by that. That's a huge increase in opioid prescription, which, you know, I mean, one of the things that we would be most concerned about would be things around, you know, whether or not there's these patterns of behaviour that get established during the COVID restrictions that then manifest later on after the restrictions are lifted. And you know, if that were the case in relation to opioids, that would be a concern.
I guess in relation to that as well, talking about sort of changes in lockdowns, we're also talking about changes, I suppose, in sort of the income policies as well. I guess with JobKeeper or other payments starting to tail off. Do you have any thoughts about that and impact on you know, sort of the income reported with these participants in particular?
Well, exactly. I mean, it's a question that we need to look at, and then we'll be monitoring the impacts. It's hard to know, and we don't really know where job seeker in particular is going to land. I mean, there's discussion about it reverting to something a little bit higher than what it was. So, you know, and I think there's it's pretty hard to make a case to taking it back to the inadequate amount that it was prior to COVID. But we'll wait and see what the government actually does.
And I think another question that's come through is related to supply issues, Paul. So this is in relation to, I think, heroin prices specifically. Someone has asked that they've had anecdotal evidence that heroin prices have gone up due to supply issues, which seems to be contrary to the data reported there. And they're curious to know if data has been collected on supply of specific substances as it could impact prices later on, and whether we're expecting that there might be a lag with that at all. I think in the data you presented, Paul, you're saying that about 40% had said drugs were harder to access overall.
Yeah, that was from the Needle and Syringe Program snapshot survey. So it is something we'll continue to monitor. It is quite surprising. I mean, so to the best of our knowledge, most of the Australian heroin and methamphetamine came in through air transport, and obviously air freight has sort of recovered from a little bit from what it was. In the immediate impact of the COVID restrictions when the borders were closed. But air traffic is still dramatically less than what it was prior to the onset of those restrictions. And so, we really did think that there would be a major drop-off in the market. And I mean, that might explain the increase in price in methamphetamine. But we're not really, we haven't really got data on that yet. So it's hard to know exactly what's going on, and it suggests that there's these massive stockpiles around somewhere, and I do recognise that some of our data are collected from the early period of the COVID restrictions, and we really need to be focusing now on what's going on. And there certainly are anecdotal other reports, and they're not necessarily anecdotal, about decreased supply. That we need to be feeding into our understanding here as well. It's not just about our data aren't reified in any way. I think they're strong because they're prospective, but our numbers are reasonably small.
I guess, thinking about the other side of the coin around supply, thinking about your data, Chris, around the opioids and the year-on-year increases. What do you, I guess, make of that data? What do you think might underpin some of those increases in opioid prescribing that we're seeing?
Yeah, look, it's an interesting thing. Some of it is, and we've seen this over a couple of other areas, some of it is the fact that a lot of care has moved to primary care from hospitals. So that will account for some of the behaviour. I don't think it's going to account for all of it, though. And I think that this is a time when GPs are trying to deal with an awful lot of stuff without the normal supports, because hospitals have closed down and mental health teams are finding difficulties with access and so forth, and they're reaching for what they know.
And so is there a concern kind of going forward that, some of those patterns might persist?
Well, yes, but the point about this sort of program is that we identify these before or earlier, and the turnaround that we have to get the PHNs to do something is weeks rather than do the research, persuade a policymaker, blah, 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 that's a year often. We can turn stuff around in weeks.
It's a bit of an early warning sign, sort of system. Mm-hmm. And, I think the other side of that is what you were presenting around the increase in sort of seeking help for mental health. That's mental health plans as well as mental health medications, it looks like, across the board. I think in terms of seeing how much of that's now being delivered by telephone, what do you make of that specifically? And, has it opened up access? Are there other, issues around that at all?
Look, I think the biggest issue is going to be just the change, the conceptual change. I think telehealth has actually always been well accepted in the mental health area, and there have been quite a few programs running it. And I think it's just actually going to make access a lot easier, but there are a lot of issues that we need to sort out in terms of clinical governance and so forth, and making sure we do the right things at the right time. And I think that, I was very reassured to see that the care plans are being done face to face, but basically the follow-ups are by telephone, and that's certainly my clinical experience, and it does make it a lot easier for everyone.
There's a question that's come through that maybe you might both want to comment on around the use of real-time prescription monitoring services and how they sort of could interface with some of this, and how they independently too provide a data set. And would providing inputs such as scripts and outputs such as dispensing, would that show the size of, say, private versus PBS subsidized medicines? I suppose that goes to you, Chris, in the first instance.
Well, I think one of the advantages of our program is that it actually does private versus PBS, because we capture everything that's prescribed by a GP. Specifically, I'm not sure about what the access to the safe script type programs is for research and analysis. My experience is with the national program, and I know at the moment any sort of secondary use of their data is well and truly tied up in a whole pile of governance processes. So it's going to be difficult.
And I guess in relation to that, would you routinely sort of discuss these data trends with providers themselves, with GPs themselves, to feedback those trends that you're seeing?
So, well, yes. So the GPs can access all of this stuff in their system, as I said, on a daily basis if they want to. The PHNs run regular programs. So it's the PHNs work with the practices. The PHNs run regular programs of engagement over, one of the problems of general practice is it's like, let's do some opioids, and the next week somebody else comes along and says, let's do hepatitis, and then let's do diabetes. And we try and work on the sort of continuous quality improvement process, so people access it as they need it. But yeah, we said we started with the bushfires, and that was literally, we saw a spike in respiratory problems, not surprisingly, you'd say, and salbutamol use, and the PHNs, were out there making sure the GPs were getting on top of it all.
Yeah, it's fantastic. In terms of the opioid prescribing, just coming back to that, we had a question coming through around whether you think any part of that increase might be related to pain management for people who might be on an elective waiting list and might be waiting for surgery. Sorry, that was for you, Chris. Yeah.
Yeah. Look. I think that is actually. I mean, I think there's again. I can tell you the what. The why is a much more complex thing. Some of it we'll be able to tell with better technology, like natural language processing. We don't, for instance, get progress notes because there's too much identifiable information in that. As I said, I suspect there's a range of aspects in that we actually need. Having looked at that graph, we need to chase them down fairly quickly, or we'll lose control.
And in relation to opioids, I guess this is a really sensitive sort of data set in terms of prescribed opioids, in terms of medicines. I guess, Paul, a question for you around, this is less about the mixed cohorts, but more around opioid markets, about whether there's any kind of contemporaneous information around what has happened around the opioid markets and opioid use during COVID. Sorry, Paul, you're on mute, I think.
Sorry. Yeah, look, I'm really not sure. I mean, I think there's clearly, it seems like there's some evidence that scripts are going up and going through the roof kind of thing. And, the unintended consequences of that will be important to monitor. We're not, so for the SuperMIX cohort who largely report using heroin, they're still reporting using heroin, basically.
Yeah. So in terms of supply, I suppose for that cohort in particular, there hasn't been a huge shift.
Yeah.
There's a few more questions that we might actually leave off some of these because I'm conscious of time. Might have to leave it off there. So I might hand over back to Dan, but thank you for some really interesting information and for a great sort of Q&A session.
Thanks, Shalini.
Back to Dan now.
Thanks, Shalini. Got to get quicker at that sort of switching. So let me just take this opportunity to really thank our three speakers and contributors, Paul, Chris and Shalini, a really fantastic insight into the many data sets that, our key researchers here at Monash hold, and, looking very much from very different perspectives in terms of those populations, and some really interesting findings for us to ponder. I see in the questions a number of people asking whether the data here will be made available. So this session is being recorded, and we'll be able to get the webinar up and live, as a recorded session for people to view very soon. And so watch this space. We'll be sending out some messages when that's available. But yes, please come and revisit. There's lots of information here, and lots of really interesting discussion points for us to really explore. And I think both Paul and Chris's data, huge amount of questions that they both raised that will be interesting to come back probably in a few months' time and really interrogate those data sets further. So big thanks to Paul and Chris, and fantastic job to Shalini for raising that issue of COVID and the impact on women in particular, and for really handling the many questions and great questions that people have raised throughout the session. Just to finish, I just wanted to highlight the Monash Addiction Research Centre webinar next month. So this is going to be nicely dovetailing the impact on alcohol, drugs and mental health as the impact of COVID on gambling behaviours, positive, negatives and vulnerabilities. And we're delighted to be able to have a really great array of contributors, Associate Professor Charles Livingston, who's head of the Gambling and Social Determinants Unit, Dr. Brian Vandenberg, a health economist here at the School of Social Sciences, and Anna Bardley, who's a fantastic advocate for gambling reform and Victorian Senior of the Year. So a really great lineup for next time. Please put it in your diaries. You'll be seeing lots of reminders around it. And again, we really want to be able to showcase, the enormous breadth of research and expertise that we have here at Monash to draw in. And if people have specific questions or particular areas that you would like us to focus on, please don't hesitate to let us know. We're really open to suggestions for future webinars, but we'll be planning for the next webinar on Thursday, the 22nd of October, and a further one after that this year. But the calendar is open for next year, so any great ideas, please share them with us. So on that note, thanks again to Paul, Chris and Shalini. Have a great afternoon, and we'll see you again in a month.